Good morning, good afternoon, and good evening to our webinar participants. My name is Konstantin Oehlmann. I am a marketing manager for intensive care at Dräger AG here in Germany. I would like to welcome you to our international customer webinar conducted by Dr. Karl Hinkson. He's the director of the pulmonary service line at Providence Regional Medical Center in Everett, that's in Washington. Karl Hinkson is a respiratory therapist with over 20 years of critical care experience. He was involved in implementing programs including early mobility, patient-driven protocols, and advanced medical ventilation. We are happy that we will share the valuable information about his experiences and challenges with immobility in the ICU with us and describing how to implement an early mobility program, including a review of outcome-based research for early mobility. But only for your information, before we start with the webinar, I would like to raise your attention to some technical instructions of our webinar system. Your microphone will be muted during the whole webinar session. If you want to ask a question, use the question or chat function in your webinar toolbox on the right-hand side. Just type your question into the field and Dr. Karl Hinkson will answer them after the presentation. You can enlarge the presentation to full screen size if you like. To do so, please click on the window button. Hope you will see this. Click the button again to bring the presentation to a normal size again. By clicking on the orange button at the top with the white arrow, you can minimize or maximize the webinar toolbox window. Please be reminded that the webinar will be recorded and will be downloaded on the Dräger website shortly after this session. Your name will not be shown at any time. Yeah. Now I would like to hand over to Karl for his presentation. Enjoy.
Thank you, Konstantin. I'm happy here to discuss my experiences with implementing an early mobility program and what I've learned about it over the last couple years. My objectives for this presentation are to talk about some of the challenges and some of the symptoms presented with post-intensive care syndrome. We're going to discuss problems with having our patients immobilized in the ICU, some diagnostic approaches to recognizing ICU-acquired weakness. I'm going to look at some safety data for early mobility programs, review the outcomes-based research for early mobility, and describe how to implement an early mobility program. So real briefly, I'm going to give you an overview of my experience with an early mobility program. Prior to coming to Providence Everett, I was at Harborview for 20 years. Harborview is a trauma center in Seattle, Washington, and they had decided to implement an early mobility program, and I was tasked to be a part of the implementation team. It was very interesting work. It was novel to me at the time. And I learned a lot of the barriers, the nuances, and the challenges to trying to start this new process in the ICU. But where first you have to understand is a kind of a newer concept is post-intensive care syndrome. Post-intensive care syndrome is something that you are seeing in patients who have survived critical illness. With the improvements in technology and our understanding of critical care and improved strategies such as lung protective ventilation, we are seeing patients with worsening outcomes after they survive their critical illness. These outcomes include deficiencies in the physical, mental, and cognitive abilities. In many cases, the research shows that these deficiencies will go on for years. Some of the more specific values is we've seen that PFT values are reduced in patients with ARDS and with critical illness. We see reductions in inspiratory muscle strength. We see reduction in hand grip strength, which is often used as a sort of a value to look at how a patient's strength has been lessened in the ICU. We see reductions in 6-minute walk test in ICU survivors. And we also see limitations in the returning to their activities of daily living, including driving and working. What we've begin to understand is even though that patients can survive a significant critical illness, they don't always return to their baseline work status. And this includes people who were quite functioning in society before their episode of ARDS or their episode of sepsis. We know that cognitive impairment is pretty common, including up to half of people who survived an acute lung injury will have it up to 1 year. And we see that anxiety and depression and post-traumatic stress disorder are pretty common in survivors. So patients who are weaker, they have poorer outcomes. We know that they will spend longer time in the ICUs, that they will be on the ventilator for a longer period of time. They are most likely to need reintubation due to acute respiratory failure. As they are weaker, they are unable to expirate their secretions, they're less mobile, and they will often go to a skilled nursing facility prior to returning home, and they will experience a long time in rehabilitation. So what we see is that even though they survive, again, to recap, they have deficiencies in their physical abilities and sometimes cognitive abilities, and a lot of them have high levels of anxiety. So as we see these patients that have long-term issues, the thought process begins to look at what is happening in the ICU that are we causing this? And predominantly in the ICU stay, we, at least when I started in critical care, when we had patients who were in ARDS or sepsis, we would do everything we could to sedate and keep them immobile. And this was thought that by doing so that we were treating the patient better, reducing oxygen consumption, keeping them still while their body recovered. But we see acute deconditioning happen. Acute deconditioning, we see changes from just several days to weeks. After a couple weeks, we'll see chronic deconditioning. And this deconditioning can impact their mood, their ability to coordinate their body, their muscle strength, and their ability to walk, their gait, their physical ability, their balance. So even though with even a short stay in an ICU, we see some deconditioning in their physical ability. Just some reminders that we can see muscle atrophy. Mitral atrophy can lose 1 to 1.5% per day with strict bed rest. And even from what we know from other medicine, like if you cast a limb, your skeletal muscle strength will decline by 5 to 6% per day. And these are the prominent muscles that are used to oppose gravity. So we consider when we take our ICU patients and place them in bed rest for even up to a week, that we can cause acute muscle atrophy. When we look at some of the diagnoses for people who are in bed rest, two kind of specific diagnoses emerge from the literature. One is critical illness polyneuropathy. And critical illness polyneuropathy is what we see as impaired oxygen and nutrient delivery to the nerves. And this is caused frequently by sepsis and hyperglycemia. Hyperglycemia, the nerves do not do well with high levels of glucose, and it makes them leaky. And as they get leaky, we see direct damage to nerves by cytokines. As another distinct process, we see critical illness myopathy, and this is increase in proteins breakdown by inflammatory cytokines. And collectively, we will call the critical illness myopathy and critical illness polyneuropathy ICU-acquired weakness, which I think is the more common term that you will see in the literature and in discussions. What are the risk factors for ICU-acquired weakness? There are plenty. Sepsis is a big one, multi-organ failure, again, hyperglycemia, catecholamine administration, duration of mechanical ventilation, being a female gender, and corticosteroids and neuromuscular blocking agents have long been identified as significant risk factors for polyneuropathy. What we see here is a sort of a breakdown, a graphic of the different mechanisms that can lead to ICU-acquired weakness. We see significant cytokine production, which can lead to microvascular changes, metabolic derangements, and electrical alterations. And we can see that all these will impair these microcirculation, impair the specific humor balances in the body, and which will eventually lead to ICU-acquired weakness. And you can review this at your leisure. There's many pathways that can cause ICU-acquired weakness, and not one specific. How does one diagnose ICU-acquired weakness in the ICU? I would say there's a couple of different strategies you can take. Physical exam being probably the simplest. However, it requires an awake and cooperative patient. So when you think about your work in the ICU, many of our patients are sedated or they are delirious and they're unable to cooperate with the exam, and the exam requires them to be able to lift their arm opposed to resistance and how strong they can do it. Other options are electrophysiologic testing. This is where you might stick a needle into the nerve, into the muscle, electromyogram, and see if there's changes. You can detect changes 24 to 48 hours after the onset of the critical illness. However, the test requires specialized knowledge to conduct, and the quality is impacted by several factors, most significant of which is being limb edema. You have to get the needle precisely placed into muscle and nerves, and having edematous limbs can make that difficult. And also, local temperature at the limb level may also impact that test. Muscle biopsy probably is our definitive diagnosis for myopathies, because then you can examine the muscle directly. However, that is the most invasive in the ICU. So most often what we will see is that ICU-acquired illness or weakness will be diagnosed empirically. And this is a graphic showing the electromyogram. And on the bottom of the screen, you'll see that what you would see is a normal test where you are sending an impulse into the nerve and you're measuring the muscle. And you see that as the impulse goes through the nerve, we have the same amplitude of impulse at the muscle. And when we have neuropathy, when we deliver the impulse to the nerve, that is attenuated, but we will still see when we stimulate the muscle, we'll still see a nice spike. And in myopathy, we will see a attenuated nerve stimulation as well as attenuated muscle stimulation. Again, this is another from the same article from Lipschutz in anesthesiology that looks how you may approach diagnosing ICU weakness in the ICU. Again, you look at trying to rule out other factors if they have MRIs, brain issues, and then you look at nerve conduction studies, and then possible nerve biopsy or muscle biopsy. And oftentimes, again, I think that most people, given the complexity of the diagnostic procedures and the treatment options, will just opt to diagnose it empirically. So a more practical approach that was presented by Jolly in 2016 was to obtain a history before their diagnosis, oftentimes from family. Early stage, consider doing muscle tests if they are able to participate, and consider doing specialized diagnostic tests if the patient is non-participatory, and this is the electrophysiologic testing, muscle ultrasounds, which is a newer diagnostic test, and then post-ICU, after they're extubated and more cooperative, you can do the hand grip strengths, the tests for other assess higher level of activities, and these are intermittent muscle tests. And then after the ICU, it can continue to do those tests and assess for their return to their activities and baseline. activities of daily living and if they can return to baseline. And what you will typically see is that as the patient has ICU-acquired weakness, you're monitoring for their ability to return to their baseline levels. Next, I'd like to move on to reviewing the safety data for an early mobility program. So, give you sort of a context. When I first heard about doing the ICU mobility program, as many of us who worked in critical care back at the time, we were very concerned about the safety of doing this modality when you consider all the lines, IVs, and specialty equipment, not to include the mechanical ventilator and the endotracheal tube. To mobilize patients was, we thought, was very risky. And the initial studies looking at mobilizing patients really looked at, could we do this safely? And one of the earliest published studies back in 2007 was from an 8-bed respiratory care intensive unit that included patients that were mechanically ventilated for over 4 days, and they began to do increases in their progression in their mobility. And they had them sit in the bed, sit on the chair, and they ambulated twice a day. And this was a team of physical therapy, respiratory therapists, nurses, and bedside assistant staff. And the outcome is, could they ambulate the patients 100 feet? And that was what their goal was they were working to. And what they found is, even though out of over 1,400 events, it was pretty safe. They had relatively few safety concerns, and most of those safety concerns were small in nature. They had a couple patients that fell to their knees. There was some blood pressure changes, 4 of which were due to orthostatic changes, and there was some desaturations, all of which were quickly resolved, and then there was one instance of a feeding tube being removed. So when you consider that out of 1,400 events, they had only those few safety concerns, and most of which were not very significant, it sort of demonstrated that you could do an early mobility program safely, at least from this initial study. So in another study that looked at early mobility, they were asking, does an early mobility program increase the number of patients in an ICU receiving physical therapy? And this is back, I would say, prior to this, when in the old state, physical therapy may do range of motion changes or range of motion therapy, but weren't very active with patients on mechanical ventilation. And so they developed a protocol to increase the intensity of physical therapy with patients, and their outcome was the portion of hospital survivors receiving physical therapy. And this is the approach that they use to increasing physical therapy for mechanically ventilated patients. And what's significant about this is, even though the knowledge about early mobility has evolved in the last decade, the protocol that most facilities employ is pretty much similar to this. And what we see here is level 1 is we have an unconscious patient, a non-participatory patient, and they would receive passive range of motion 3 times a day. The bedside staff still turns the patient every 2 hours. And then we move on to sort of if they can do this, then let's move them on to the next level. If they are conscious, we can continue to do some passive range motions and we continue to turn them, but we can do some active resistance physical therapy, and we place the patients in the sitting position. And if they can go to the sitting position, then we can move them to the next step, which is, if they can sit, then let's have them sit on the edge of the bed and then dangle their feet. And this allows them to move their limbs and their legs against gravity. And we take that for granted, but moving our limbs against gravity does maintain a significant amount of strength and resist that muscle atrophy. From the pulmonary standpoint, even if they can do just that level of activity, that benefits us because that helps them maintain their core strength and their thoracic strength, which will help their cough in their pulmonary toilet post-extubation. If they can sit on the edge of the bed, then we consider having them stand. So that's the next step. If they can do all that above, then we can have them stand. And if they can stand, let's have them transfer to another chair. And if they can stand, transfer to another chair, let's consider having them walk. And on the right-hand side of the screen is safety criteria, which is the respiratory therapist or bedside nurse, you always want to be cognizant that your facility has developed some safety criteria to either monitor either you, if you, for example, you have a PEEP of 15 and 80%, or you're on high APRV settings, maybe you don't want to have your patient do that much activity. But if they're on moderate settings and they're not on vasopressors, you may consider that they are safe to do this type of activity. But if you want to have some criteria that if there are changes, they become hypoxic or they become hypotensive, that you limit stop the therapy, stop the progression, and have them rest. So in this particular study, they did see that they were able to increase the amount of physical therapy that patients received in the ICU. So more patients were seen by PT in the hospital, they had more sessions. And what was interesting is that because of this, because PT began working with the patient sooner, they were able to get the patients out of bed sooner. And in this early study, they showed a shortened ICU stay and hospital length of stay. But the duration of mechanical ventilation was not significantly different. What's important to note is in this early event is that they saw no increase in costs. Where you would likely see your increase in costs in the facility would be that you have to hire more staff to deliver this type of care. And they were, in this small study, they were able to deliver the care with the existing staffing model that they had. So there was no significant increase in costs, and there were also no adverse events. In a more larger study, looked at just specifically looked at safety. Dr. Nidal, and published in 2017, looked at the reports of adverse events in early mobility, and what you can see is out of quite a few early mobility sessions, the reported event rate was significantly lower. I think it's, I did the math, and there's about 2.6% adverse event rate per early mobility. And when you consider that we have done thousands of early mobility events, and this is having patients sit up, having patients sit on the edge of the bed and have them walk, that the event rate, the adverse event rate, is actually pretty low. So what are the outcomes for having an early mobility program? There are several now larger randomized controlled trials that have looked at having an early mobility program. Schweickert, Dr. Schweickert in 2009 published one of the earlier ones. In this one, they looked at MICU patients that required mechanical ventilation for more than 72 hours. They implemented a early exercise and mobility program that coupled the daily interruption of sedation with the usual PT/OT. And their primary outcome was how functional independently, or how physically functional these patients were at discharge. And they were looking at 6 specific ADLs, and there were other outcomes, was a reduction in delirium and hopefully a reduction in duration of mechanical ventilation. The idea being if they maintain the patient's functional status, they could get the patients off the ventilator sooner. And what we see in the outcomes, I mean, this is a relatively small study, about 50-50, about a total of 100 patients, 50 in control, 55 in control, 49 in intervention. And we see that in the intervention, they received physical therapy much sooner. The other significant outcome of this was the intervention groups, they had more returns to their activities of daily living at discharge. So they were more functional at hospital discharge. Another interesting outcome is that they were able to walk a greater distance at hospital discharge as compared to the control group. And when you look at milestones, they were faster to these milestones than the control group. They were sooner to get out of bed. They were sooner to be able to stand. They were sooner marching in place, getting to another chair, and walking. And this makes intuitive sense that if you begin the therapy sooner, if you provide better care to the patient, even when they're intubated, they may reach these milestones sooner. Other outcomes that were of note, more patients were able to return to independent functional status at discharge, so they did not have to go to skilled nursing facilities, so that has some community health benefits. There was fewer ICU delirium. There was less time with delirium, and in this particular study there were fewer mechanical ventilation days. They were able to get the patients off the ventilator sooner. And this is a graph showing that their ability to return to functional status was significantly higher than the control group. So this study resulted in some benefits to patients just simply being more functional at discharge following their critical illness. This study was followed up by another one. Again, kind of a smaller study, a total of 50 patients. Their primary outcome was using a physical function test, the SF-36 telephone question, which is a questionnaire that's done over the phone post-discharge, and they had some secondary outcomes using a MRC score and measured some cytokines. So again, this was where they did more intensive study, and we can see in the graph here that the patients who received exercise had better physical function, better physical role, less bodily pain, a better emotional role, but also as of interesting note, they had differences in their inflammatory markers, most significant of which was the IL-6. One of the larger studies was done by Morris that was published in JAMA 2 years ago. This was over 300 patients, pretty good size, had 150 in the control. And in this particular one, the standard rehab therapy was normally what was done in the ICU was compared to progressive physical therapy with increasing intensity. And the primary outcome in this one was hospital length of stay. There were other secondary outcomes that included ventilator length of stay, physical outcome at discharge, and a mini mental state exam. What's interesting to note in this particular study is that the usual care did not result in much improvement over the more intensive physical therapy. On these outcomes, it's a big slide. Apologize for having a lot of the data, but not a lot of significant values in this particular graph. And one of the, I might say, one of the criticisms or the biases of that study is when we look at how care has been provided, we may be teaching the nursing staff and the respiratory therapy staff to be more assertive in doing early mobility programs. So even though you may not have physical therapy coming to the bedside, that the other bedside caregivers are doing more therapy with those patients. So that may have biased the results. Another study, this is a meta-analysis that looked at several randomized controlled trials, looked at physical therapy versus the usual care, and when we look at these randomized or these meta-analyses, we want to look at the diamond, and some of these don't include a lot of studies, but we see that the meta-analysis are favoring the early rehabilitation for different groups when you look at the different slices of the study. Which is less clear is, are they able to make a difference on having delirium-free days or mental health related outcomes? And so what we're seeing from some of this is that we are definitely making an impact on the physical outcomes, less clear on the mental health related outcomes, and some of the other, based on how they slice the data, health related scores and some other physical scores. So what are the costs associated with having an early mobility program? Oftentimes there is concern from the part of the C-suite that having an early mobility program is expensive because you have to have more staff doing time-intensive therapy. And this was the post-analysis of particular studies looked at the costs of having early mobility programs and differences in the outcome. So they looked at two different studies. They assigned some costs to the Morris study and another Rosenbaum study, and they showed that in the Morris study that with the early mobility program, the cost of care was around 41,000 American dollars as opposed to $44,000 when you had the usual care. And what we can kind of see is that when you have no early mobility program, you will have more time spent in the ICU, or it's perceived that you will have more time spent in the ICU, which is the most expensive place to care for the patient. With an early mobility program, presumably the patients will spend less time in the ICU and they will be more functional as they are discharged and will have lower costs. And on the table on the right-hand side of the slide there demonstrates that an estimated emissions per year based off of this analysis, the hospital savings. So an estimated savings, if you have 200 admissions per year, you would save about $34,000. And as the admissions go up, so do the cost savings. So the argument for having an early mobility program is, yes, you are spending more intensive time with the patients in the ICU, but they'll be in the ICU for a lesser amount of time, and they will require less intensive therapy as they progress through the healthcare continuum. Next, I would like to talk a little bit about implementing an early mobility program, kind of what you need to be successful, and maybe hopefully learn from some of my experiences. What you would definitely need to be successful is you need to have administrative buy-in. There are sometimes considerations for having more staff, particularly more physical therapy staff. It is more time intensive for nursing, for respiratory therapy. So making sure that as everyone is very concerned about their productivity and that their expenses, that you have administrative buy-in to begin the program and then give you the opportunity to demonstrate the benefits of the program, and so that you can demonstrate the cost savings to the C-suite. Another key element is you have to have a physician champion. The physician champion is essential to negotiating with the other attendings to successfully implement the program. They have to help educate everybody and be that sort of go-to person to champion the cause. And you need to have a multidisciplinary approach. It is best that if it's not just nursing, not just physicians, not just physical therapy, or not just respiratory therapy, that this is a true multidisciplinary approach. And spend a lot of time overcoming misconceptions about early mobility. When I started my first, I didn't start it, but when I was a part of starting our first early mobility program, there were a lot of conceptual barriers to overcome, and we were struggling with why we could not get the patients up and moving. And what we finally decided on doing was we set up specific rounds in our medical ICU to round on the patients for the express purpose of discussing what were the barriers to early mobilization. And what was so beneficial about this is it was a physician, a nurse champion, a respiratory therapist champion, a physician, a psychiatrist who was an expert in delirium, And when we rounded with the bedside staff, we would often run into misconceptions about early mobility, or I would say most significantly was delirium. We had learned that we were frequently over-sedating our patients, misdiagnosing delirium and causing them to fail from that angle. So we spent several weeks re-educating the nursing staff, the respiratory therapy staff, the bedside staff about delirium, trying to limit benzodiazepines, overcoming barriers such as you would have a patient that the staff would decide was too sick to do any movement on, and then re-educate them, well, this is actually quite safe, and you can go ahead and sit them up. You can go ahead and have them sit at the edge of the bed. And a lot of, I would say, reassurance to the bedside staff, but really having discussions about what are the perceptions to the barriers, what is your level of comfort or education. So I'd say a lot of re-education on what the actual mechanics of a program are. There are a lot of safety concerns. There are a lot of concerns over accidentally dischargement of the medical devices, the endotracheal tube being most significant, vascular devices, potential complications from increased activity with hypoxemia, hemodynamic, and patient comfort. And these are often the perceptions of the bedside staff, not necessarily the caregivers themselves. And we've actually did a lot of early mobilization with endotracheal tubes, and the respiratory therapist can guard and be aware of the endotracheal tube. It does not come out. You can guard the IV or the central line, and it does not come out. There have been case reports of patients being actively mobilized while they're even on ECMO using an Avalon catheter. They can be safely mobilized. So if you are mindful, if you are cautious in your approach, if you secure the device appropriately before you leave the bedside, then these are not really barriers. These are just concerns and things to watch. Sedation and delirium, this is a significant barrier if you are not actively assessing for delirium in your ICU, and you hear a lot of conversations about the ABCDE bundle. Early mobility is a part of the ABCDE bundle, but so is delirium. If your patients are delirious, they will not be able to actively participate in the mobility program. And initially that was the buzzsaw that we ran into when I was at Harborview when we implemented the program, is that many of the patients were just too sedated. They were too delirious, and we were not accurately assessing the delirium. So we had to do a lot of re-education, around using the CAM tool. And once we were able to get a handle on that, we were able to begin the activity and decrease those barriers for the staff. Again, cost is an issue. It's not really an issue unless you're hiring more staff, but from the perception of the staff, this requires more of their time. They feel that they sometimes have less time for other patients. And each facility needs to address this on their own. If you're only mobilizing, walking 1 or 2 patients a day, that's not a significant increase to the workload. But if you're walking 10 patients a day, that may be an increase. So another kind of barrier that I was unaware of is that some early components of an early mobility program may not be skilled therapy for physical therapy. And so in those cases, you have to train the nursing staff and the RT staff enough that they can do the mobilization of the patients. Again, it's not a barrier. You don't need a PT person to sit up a patient in bed or have them dangle their feet. You may need some assistance to have patients initially walk, but if they don't need skilled therapy, you don't need to have the physical therapist present. In one case, an instance, I recall caring for a cystic fibrosis patient who was essentially ventilator dependent, and they were awaiting a lung transplant. As part of their plan to improve their health for the lung transplant, the patient was very motivated and began sort of their own activity routine. And I will say that they were quite mobile. We would routinely actually go for walks around the hospital on the ventilator. PT was not present at that. It was just the respiratory therapist, the nurse, and some members of the patient family. Again, go through the progression. So there's sort of a standard process to having an early mobility program. It's not all about just walking. It's about increasing the activity for the patients. You want the patient to sit up in bed. You want them to be able to dangle their feet on the edge of the bed. Have them, if they can do that, then have them stand up and bear weight. If unable to bear weight, if unable to bear weight, you can move them to the cardiac chair and assess for reasons that they can't bear their weight. If they can move to the cardiac chair, move them to the commode. If they can move back and forth, see if they can ambulate with a walker or a portable ventilator. And if they can do this stuff, you can take small steps. Have them walk across the room and back to their bed. Each of these is sort of a progression in increasing ability. And as you can increase this ability, you can also increase the frequency of the mobility. Oftentimes, I think I use an analogy that you don't just have somebody go to the gym and start bench pressing, 300 pounds. They have to work their way up to it. It is very similar for patients working or patients living critical illness in the ICU. They have to work their way up to being mobile, and we sometimes lose sight of just how deconditioned we make them with our critical care. So what is the role of every clinician that supports the program? To make sure that we help screen patients and encourage mobilization, I would say that would be the number one. Be cognizant of the barriers of early mobility and be actively working to resolve them. We want to ensure that our spontaneous awakening trials, our SBTs, are done daily. We want to adhere to the ABCDE bundle. While we're mobilizing patients, we want to be monitoring the patients for safety if they're having any adverse changes in their hemodynamics, desaturations. We want to be able to manage a mobile vent, protect the endotracheal tube, and again, you want to document the patient progression. We are participatory in the multidisciplinary team, and we want to continue to hand off the information for the shift. Before you leave, you want to make sure that you suction the patient, you give any bronchodilators if indicated, double check your airway, double check your equipment, and discuss what your mode of ventilation is. There is no set guidelines for a particular mode of ventilation. However, particular modes like the Smart Care on the Dräger are very beneficial. You want a ventilator mode that can adapt to the patient's changes. Smart Care does that very nicely. As the metabolic demands increase and the patient workloads increase, it can increase the level of support to meet them. And when they're done with their mobility and they return back to baseline, it will also decrease the level of support. Also consider increasing your FiO2 to help with the increased metabolic demand, and make sure that all the equipment that you're leaving with is functioning. Ventilator, suction, your oxygen tanks, monitoring equipment. In some instances, especially with patients who are long-term in the ICU and are really debilitated, they sometimes will go out past the ICU. We have taken ICU patients to outside the hospital to the parking lot. Again, there was one patient that would literally try to do laps around the hospital, which also brings up another kind of key safety point that you can take my experience. Yes, patients can mobilize on this, but you have to keep in fact that there will be somebody working hard to push a ventilator behind them. And I've seen some caregivers actually get a better workout than the patient trying to keep the ventilator up. So keep safety in mind. It's not useful to have somebody trying to lift a ventilator over a street curb. And in some instances, you may have to investigate actually taking a patient to a treadmill. Those cases are very rare, but it highlights the option that if you are or highlights that if you have an active mobility program, that is something that you may have a patient who increases their mobility to that level but can't come off the ventilator. Are we going to limit their amount of physical activity because they're simply on a ventilator even though they physically can do it? These are things you have to decide for yourself. So what does mobilization look like? Oh, it's a practical example. These are some pictures of patients early mobilizing. This one here, you can see that a caregiver has the IV pole with some pumps, and then another caregiver is having the ventilator behind them and is watching the ventilator circuit, and the patient is mobilizing. That is exactly as they go down the hallway. This is not in a patient room. Consider the psychological benefit to the patient that even though they're on a ventilator, getting outside the room, getting to change their environment is mentally beneficial to them. They get to participate in their care at this point. Here's another example of a patient ambulating while on a ventilator. And again, you see the caregivers around them kind of being mindful of the patient and the equipment. So with 2 to 3 staff, it can be done very safely. So to summarize, post-intensive care syndrome, it's a now recognized syndrome that is a consequence of patients who have survived critical illness. It has physical, cognitive, and mental alterations. And the only real treatment that we have for it, there's no medication that we give, but early mobility is really the only potential mitigation to ICU-acquired weakness and potentially to post-intensive care syndrome. Early mobility is safe for patients who are receiving mechanical ventilation. The number of complications or instances is very low. Outcomes for early mobility is mixed, I would say, because of the one large randomized controlled trial that didn't demonstrate benefit. But a lot of the smaller studies have shown that early mobility does improve get patients to a improved functional status better, and with require more functional at discharge. But in order to have an essential program, clinician buy-in is imperative, and you have to keep looking for overcoming those barriers and those misconceptions. Good application of the ABCDE bundle is imperative.
Maybe first, thank you very much, Carl, for this great presentation.